Good morning, everybody. So yes, two important abstracts. Do tumor-infiltrating lymphocytes or TILs predict benefits from trastuzumab therapy for HER2-positive breast cancer? Meta-analysis of 4168 females in 5 randomized trials. So this is a common question that we feel tumor-infiltrating lymphocytes are prognostic in breast cancer, especially in triple-negative breast cancers. And yes, better outcomes are seen with higher score. There was a FINHER study which also said that there was a significant interaction between TILs and trastuzumab. If you have higher TILs, these patients respond well to trastuzumab. So let's see if we can validate this further. So this was a study taken up to answer this particular question, to reproduce these findings, and also to see the prognostic as well as the predictive importance of trastuzumab. So 4097 females in 5 randomized trials were taken and TIL was assessed. Primary outcome was time to first recurrence. So median was just around, the TIL was just around 13%. Only 10% of patients had it above 50%. But yes, the prognostic significance was established. As you can see, patient who had higher degree of TIL expression, 0 to 9, 10 to 19, 20 to 29, or 70 and plus. So the recurrences, with every 10% increase in TIL, the recurrences went down. And with every 10% increase in TILs, the recurrences went down by 14%. And also, because the TILs were higher, there were lesser recurrences. So yes, lesser events in the patients who had higher TILs. So overall, there was a highly significant benefit of trastuzumab on recurrence, but no evidence of any interaction between TILs. So yes, prognostic significance was established, but not the predictive one. Any TIL, 0 to 9, 10 to 19, 5 groups were established to see the predictive significance, but you see the HR for trastuzumab. And no difference in the predictive inputs for the HR, trastuzumab responses were seen. So the authors concluded the analysis confirms prognostic effects of the TILs in this population, no evidence of a natural cutoff. There are certain studies, they are still, the good thing about TILs, they're easy to do, and now we have established criteria so that they can also be reproducible, and objectification can also be done of the various cutoffs. They can be reproduced in various blocks. But we don't know what is that cutoff where you can actually safely say that this is the TIL which you should take in the clinical criteria. Some studies have said that it might be 60%. For every 10% increase in the TIL rate of recurrences, lessens by 14%. No group with a very low risk of recurrence identified. However, a small number of patients with high levels or node-negative tumors. But importantly, no evidence of interaction between TILs and effect of trastuzumab, unlike the FINHER results. Substantial absolute benefit of trastuzumab irrespective of the TIL status. So good thing is, large meta-analysis, prognostic significance established but not predictive, limited number of events in patients with high TILs. Now, why did it have a difference from the FINHER analysis? FINHER was a small study, 209 patients were there. It was a prospective, retrospective analysis. Also, we know that there might be interaction with other therapies. We don't know the impact, whether it was impacted by the chemotherapies. Also in hormone receptor positive patients, they were given hormonal therapies, so we don't know the interaction of those therapies. Also, most of the studies are actually doing what is called as the stromal TIL estimation, and there's something called as intratumoral TIL estimation. So we don't know if one of them might become a predictive marker. So that also needs to be looked at. The second study is HER2 amplification level by in situ hybridization predicts survival outcomes in advanced HER2 positive breast cancer. So this is advanced HER2 positive breast cancer treated with dual HER2 blocker, pertuzumab, trastuzumab, docetaxel, regardless of HER2 ISC results. So the role of HER2 amplification, we are all very well aware of. We also heard the results of Cleopatra, the study design as well as the results. The role of HER2 amplification is predicting the effectiveness of HER2-directed therapies has been established. However, its association with survival outcomes in advanced HER2 positive breast cancer treated with dual HER2 blockade remains unexplored. So this was again a small study, single center retrospective study of patients with advanced HER2 positive breast cancer treated with first-line pertuzumab, trastuzumab, and docetaxel. The primary objective being to investigate predictive role. So again, a predictive role of HER2 amplification level on survival, PFS as well as OS in advanced HER2 positive breast cancer patient treated with these agents. So this was a Korean study. They took the patients from 2014 to 2021. Overall eligible patients were 152. Both de novo as well as recurrent patients were taken. Ultimately, the ISH was analyzed in 78 patients. HER2 1+. So that is what is important. I don't think so. We actually do in any patient this when you have a HER2 1+. I don't think we do ISH, but here you just see that overall 2 patients were such, where the HER2 was 1+ and the ISH was done, and the patients were given the therapies. So Now, how many chemotherapies to give was decided by the clinician, and as many as 40 chemotherapy cycles were also given. Overall, 86 patients end on becoming long-term responders. How did they define long-term responders? Longer PFS than the median PFS from the Cleopatra trial, that is the 18.7 months. Median PFS of these long-term responders were 41.4 months. And they compared the results between long-term responders and non-long-term responders. No significant difference in the age, metastatic site, hormone receptor status, or HER2 IHC. But they did find that the significantly higher HER2 oblique CEP17 ratio of long-term responders. Median was 4.68 compared to non-long-term responder, where median was just 3.71. And also for the 78 patients who received AISH, higher HER2 and this ratio correlated significantly with the longer PFS and overall survival, with the HR being 0.50 and HR being 0.28 for overall survival, and dichotomized by median. So that was 4.13. Also, higher HER2 copy number also correlated significantly with a better PFS. In multivariate analysis, this ratio independently predicted factors for the PFS and potentially for OS, and also similar degree of benefit was seen with the higher HER2 copy numbers. So the authors concluded first study to report a higher level of HER2 amplification by AISH is associated with improved PFS and OS in advanced HER2 positive breast cancer treated with dual HER2 blockade. And HER2 amplification level has a predictive role regardless of ISC results. Even in the patient with HER2 protein expression of 3+, treatment outcomes to HER2 directed therapies was dependent on the level of HER2 gene amplification. So it would be helpful to perform AISH not only in patients whose HER2 ISC result is ambiguous, but also in the patients with HER2 ISC 3+, to improve the prediction of the treatment outcome. So this is a retrospective study, small sample size, but the strength is that no study has yet evaluated the predictive role of HER2 amplification level in advanced HER2 positive breast cancer treated with dual HER2 blocker. And it tells you that maybe not all IEC 3+ are same, but it also raises the question, should reflex IEC be adopted? The other important consideration is now because trastuzumab deruxtecan is coming, which you know that you're using, the data is emerging across HER2 low, HER2 high. So maybe when you find out your values, it will help you to decide that which patient population is more suited for trastuzumab deruxtecan versus dual HER2 blocker, especially after the results of Destiny 9 month comes. So that will be all. Thank you.